Hello. Today we will navigate the challenges around the diagnosis and management of systemic mastocytosis with a look at the current and emerging treatments, and we will highlight the disciplinary character of the disorder. I'm happy to be part of this panel. My name is Vito Sabato. I'm an allergist, immunologist at Antwerp University Hospital. I'm joined today by colleague Prithvi Bose, who is an haemato-oncologist at Anderson Cancer Center in Texas, USA, and Sigurd Brusby Holsen, a dermatologist and allergist at Odense University Hospital in Denmark. And the first point, of course, is we will discuss how the systemic mastocytosis is diagnosed, and we will explore the patient journey. And systemic mastocytosis is driven by an abnormal expansion of the mast cells, a clonal expansion of the mast cells on one side, and on the other side, an uncontrolled mediator release. This is a disease that can be limited to the skin or can be multi-organ, and goes from cutaneous form to systemic form, with or without systemic involvement, and with a presentation that ranges from indolent to aggressive disorder. In most of the cases, especially in systemic disorder, there is a key mutation that affects the stem cell factor, the so-called KIT, and usually this is the KIT 8 CCV. In most of the cases, the main symptoms of mastocytosis are anaphylaxis, gastrointestinal symptoms, flushing, pruritus, fatigue, and there is also an important involvement of the bone with osteopenia and osteoporosis. And I would now like to invite my colleagues to discuss about the diagnosis. And I will start with Dr. Brusby Holsen about which are the typical presentation of mastocytosis. How can we recognize mastocytosis?
It's difficult to recognize mastocytosis for let's say, the normal doctor or healthcare professional. It's underdiagnosed, and it's really important to know what to look for. Now, you showed pictures of the skin, and many patients do have like characteristic skin lesions called urticaria pigmentosa with a classic Darrier sign. But some patients do not have these skin lesions, so it may present as a skin disease, and dermatologists need to know of this and need to recognize that adults with the disease need a full workup, whereas children is another story. We might come back to that. But it may, yeah.
Sigurd, sorry for interrupting you. Could you tell us more about the Darrier sign? What do you mean?
Yeah, it's kind of a unique sign for mastocytosis in the skin. It's what patients they feel like an itch or like a wheal and flare response upon rubbing, and you may use it in the clinic, where you could use something like a wooden tongue scratcher, for example, or a similar instrument, and then rub the skin lesions like you would do like a moderate pressure, and then wait what you like you would do for a prick test. You will see a wheal and flare response upon the pigmented skin lesions. That's a pathognomonic sign of mastocytosis, so Darrier sign.
Thank you very much. I mean, you touched the children and adults. Is there also any difference in the clinical presentation of the skin lesions? And do we need a different approach when we consider children and adults?
Yeah, in general, you say that children, they have disease confined to the skin. And we are happy with the clinical diagnosis, whereas in adults, it's the skin involvement is more sign of the systemic disease. Like you need a full workup to fully diagnose those patients. So that's a major difference between those two. And on the clinical side, you showed pictures of nice uniform or monomorphic skin lesions in adults, like small macular spots, flat spots, symmetrically distributed. Now, those may look like that in children as well, but they may also be bigger, bigger and smaller, intermingled, what you call, let's say, not monomorphic, but polymorphic skin lesions. So there is a difference in the clinical appearance of the skin lesions as well.
Thank you very much. We will touch the skin afterwards, but let's move also. I mean, we say that mastocytosis is a heterogeneous disorder. We have indolent disorder. We have advanced disorder. Prithvi, could you tell us more about how our patient will present to your clinic when he has an advanced form of mastocytosis? Is there any difference between the indolent form? There are specific clinical features?
Thank you, Vito. So, as a hematologist, I will receive most of these patients as a referral from either an allergist or a dermatologist like yourselves, or a GI sometimes. Uh, I do see a large number of patients with indolent disease actually, and of course I'll come to the advanced as well. But the indolent disease, typically there's a variety of presentations. So I'll give you some examples. Of course, it could be a rash, like Sigurd has nicely elaborated on. It could even be osteoporosis, which is unexplained, and the endocrinologist checks a tryptase and it's high, and that leads to the referral. It could be, of course, an allergist who sends the patient because there's either a history of anaphylaxis or there are just mast cell activation symptoms. So a variety of different types of presentation, occasionally GI as well. Lots of diarrhea, a GI endoscopy is performed, biopsies are taken, and the mast cell aggregates are discovered. Now, for advanced disease, of course, advanced SM is much less common than indolent SM, but typically those patients come to somebody like me. I work in the leukemia department at MD Anderson. Many times they'll come in the context of not the SM per se, but the associated hematologic neoplasm. Because most advanced SM, as you know, is SMAA gen, or associated hematologic neoplasm, where that might be really what drives the presentation, and then the SM might be incidentally found. In the advanced SM cases, the symptomatology is actually a bit less in my experience than in the indolent cases. So I think it's a disease with a very large, wide variety of clinical presentation.
Thank you. Thank you. This highlights again the importance of the multidisciplinary collaboration. But I have back a question, because we mentioned anaphylaxis, and I am an allergist. And could you tell Sigurd more us about anaphylaxis in mastocytosis, whether anaphylaxis has some kind of peculiarity that distinguish anaphylaxis in patients without mastocytosis? Could you tell us about that?
Yeah, I'm happy to. I mean, I'm also just supporting, like Dr. Bose, showing the wide range of patient symptoms here, and anaphylaxis is definitely one of them. Now, not all our patients face that, but especially among patients with Hymenoptera venom anaphylaxis, you really need to look for mastocytosis. They may not have skin lesions, they may not have elevated tryptase, but they may have severe anaphylaxis with syncope. And the tools that you have there is like, you need to look for the clinical picture, and the very severe patients, you may want to do a bone marrow in those patients. You have another tool called KIT D816V mutation analysis in peripheral blood. We do see patients on that account as well. So I'm just, I do want to emphasize that among patients, especially Hymenoptera venom anaphylaxis, but also patients with severe anaphylaxis, perhaps spontaneous anaphylaxis, you need to look for mastocytosis. It's to me, my opinion, widely underdiagnosed in this population.
Thank you very much. So actually, we touched the clinical presentation. We touched also the mastocytosis might present with or without cutaneous lesions. We touched the features of the cutaneous lesion, but let's go further. When I suspect mastocytosis, which step I can take? And Petri, can we start? Which kind of blood test I can ask?
If SM is suspected, as you said, I mean, I think a bone marrow is critical because most patients, and Sigurd already alluded to this, adult patients will typically have systemic disease, not just cutaneous disease. And really, the bone marrow is the best place to look. So I think apart from a serum tryptase, which of course is a blood test, I think the rest is, we would typically do them on the bone marrow, which is things like the myeloid mutation panel. Most centers will use NGS. Now, it's important to note that NGS can miss the KIT D816V mutation if it's at a very low allele burden, which often is the case in ISM. And therefore, it's really important to use a highly sensitive assay like digital droplet PCR or allele-specific oligonucleotide PCR, ASO PCR, to detect the KIT D816V if it is negative on the NGS. So I would do a bone marrow with karyotyping and NGS, reflex testing for KIT D816V if negative on the NGS, and I would get a serum tryptase.
Yeah. Well, Sigurd, I know you have done some pioneering work on the detection of the KIT mutation in peripheral blood, but can you tell us about the correct use of them? By the way, if I ask this test in peripheral blood and this is negative, can I exclude mastocytosis, or can you give some granularity?
Yeah, it's really nice to supplement each other here, because I completely agree again with Dr. Bose, but like moving one step before that, in the allergy, for example, patients with other unspecific symptoms, you need some kind of selection on who to do the bone marrow, and I think we agree, everybody, that tryptase is not specific for mastocytosis anymore. So you can find mastocytosis among patients with normal tryptase, and you may not have systemic mastocytosis, even though your baseline tryptase is even beyond 20. So this is where, to my opinion, the KIT mutation, D816V mutation analysis, as a highly sensitive method used in peripheral blood, is another tool to really find those patients. Patients with subtle symptoms, among patients with anaphylaxis, for example, or more diffuse symptoms, even among osteoporosis patients. It may be a better way to choose on who to do the bone marrow if the skin lesions are not present. But it's not a perfect tool, but at least used in combination with the tryptase, with the clinical picture of the patient, you may select the true patients to diagnose on a bone marrow exam. That's my opinion, at least.
Thank you. So let's say,
I completely agree.
Thank you. Let's say we agree on the patient that will undergo the bone marrow, but what are the tests, what are the characteristics of the bone marrow that they are looking for making a diagnosis? And there are criteria that have been established to make the diagnosis. Could you tell us more about that?
Yes, I think, what's really being looked for in the bone marrow or in any other extracutaneous organ, as you will show us with the criteria, is really these aggregates, right? So it's not just the mast cells present or even in increased numbers. You really need to see them in multifocal aggregates of mast cells. And then, of course, there are other criteria which we will come to about the spindle appearance, etc. There is a very rare variant called well-differentiated SM where the mast cells are not spindled. But in general, you see the spindle appearance, and importantly, you find them in aggregates or clusters.
Well, thank you. Well, correct me if I'm wrong, but of course the aggregates usually relates with the burden, and we have some patients with anaphylaxis where aggregates might not be found. Sigurd, would you agree on that?
I completely agree, and I just want to emphasize that diagnosing a systemic mastocytosis on a bone marrow is not trivial. You need experienced pathologists to do this. We have several cases where they were initially overlooked on a bone marrow. I think we would agree, Dr. Bose, on that, and also using a highly sensitive flow cytometry because some of the patients do not have these aggregates. They may have more subtle, let's say, signs of systemic mastocytosis. We're coming back to that, I know. Just saying it's not trivial. It's not ordering a bone marrow and then expecting that to be perfect. You need to make a good collaboration with the pathologist to know what to look for, how to, let's say, interpret the different analytic methods.
So that means that eventually for this kind of disorder, since also is a rare disorder, it's not a bad idea to have a reference center just to be sure that the cases are not overlooked. What do you think about?
Yeah, I think this sort of a condition, you absolutely need the expertise of a center of excellence. This is, as Sigurd mentioned, this is not easy for the pathologist either. And I completely agree. Flow can be very, very helpful for CD2, CD25, CD30, can be a very, very important adjunct to the morphology itself. But absolutely, you need a center of excellence. You need high volume centers to be able to really do a good job with diagnosing this.
Well, thank you. Well, we have heard about the diagnostic workup, we have heard about tryptase, we have heard about the bone marrow, and actually we have criteria that are defined as major, as minor criteria. The aggregates counts as major criteria, and then the minor criteria actually are intended to find morphological or immunological abnormality in mast cells, and again to find the mutation that we have heard. And actually, when the patients fulfills one major and one minor criteria, or at least 3 minor criteria, we speak about systemic mastocytosis. But then what we do for refining the diagnosis, because we have said mastocytosis can be advanced, can be non-advanced. I've heard from you about B or C findings. Can you tell us more? And what do they mean? Let's start from the B finding, Sigurd, and then we go to the C finding, please.
Yeah, so the indolent disease is like it's also a little bit a spectrum, and now we have a specific subtype of systemic mastocytosis called smoldering systemic mastocytosis, where the mast cell burden is high, where the organs might be enlarged, but it doesn't really affect the function of the organ. That might be the bone marrow, that might be the liver or the spleen. So there's like an intermediate type of systemic mastocytosis between indolent and aggressive systemic mastocytosis, and this is where you need the B findings to properly diagnose.
So let's go back to the C finding. Can you tell us more and why are so important?
So C findings are the hallmark of advanced SM, and in particular when we are talking about just SM, pure SM without an associated hematologic neoplasm, more correctly, it's the aggressive SM entity, which is defined by C findings. So C findings are C for consider cytoreduction. That's where the C comes from. So the C essentially indicates organ damage, where there are mast cells infiltrating and causing organ damage. So some examples are low blood counts, ascites, weight loss from malabsorption due to GI infiltration, a large spleen with low blood counts, in other words, hypersplenism, enlarged liver with liver function abnormalities, hypoalbuminemia, all these types of findings, as well as large lytic bone lesions, are C findings.
Well, that means that those findings help us in defining the category of mastocytosis, and mainly the distinction between advanced and non-advanced form relates with the survival of the patient. Hello, we are discussing about the current treatment options for patients with systemic mastocytosis, with advanced and non-advanced form of mastocytosis, and the key consideration for the use in individual patients. I'm Vito Sabato, I'm an allergist, and I'm happy to be joined by Prithvi Bose and by Sigurd Brusby Olsen. When we approach the treatment of mastocytosis, taking into account the different variants of mastocytosis, we have different goals. And if we look at the indolent form, the goal is mainly the improvement of quality of life of those patients and improvement in symptoms. Whereas if we go to the advanced form that most affect the survival of the patients, the main goal is to improve the survival of the patients and to delay the disease progression and reduce the risk of organ damage. And it's of utmost importance that those patients maintain the ability to do the usual activity, that there is a reduction in anaphylactic episodes, and there is a normalization of the blood counts. But I'm happy now to invite my colleagues in providing their expertise on the treatment. And let's start from the non-advanced form. The first question, Sigurd, is every patient with a non-advanced form needs to be treated or not? What do you think about it?
I think you need to make sure, first of all, that the patient is on the right track, that they have some counseling, because the World Wide Web is full of information that may be disturbing to our patient, may be confusing. So you need some expert counseling. You may want to underline that this is a disease with a normal life expectancy. And then the next step is to make sure what is actually the patient's symptoms. So, and there you want to map the symptoms and to make sure that you're actually helping the patient. So, and antihistamines, non-sedating antihistamines is a way of at least helping with some of the mediator-related symptoms, and you may want to updose that. That may alleviate some of the itch, may to some extent help on the GI symptoms. And then you build on that, and we do have some off-label use of omalizumab, but it's not available in all countries. It's anti-IgE. You mentioned the anaphylactic risk. Of course, you need to counsel the patient on that. We do provide adrenaline auto-injectors for our adult patients to make sure that they have, let's say, the ability to treat themselves in the case of an emergency episode. So I guess my main message is that you really need to tailor the approach to the individual patient because they are so heterogeneous.
Well, thank you. You mentioned anti-mediator therapy, but I've heard actually that recently new drugs have been approved for indolent disorder, and those drugs can be disease modifying. Petri, can you tell about this, please?
Happy to. Yeah, so avapritinib was approved in 2023 for indolent SM, really the first targeted therapy to be approved for indolent SM. And this drug, of course, was approved 2 years prior to that for advanced SM at a different dose. But in terms of when this is indicated, I would say if one looks at the pivotal trial Pioneer that led to its approval, patients had to have symptoms despite at least 2 anti-mediator therapies, like Sigurd was alluding to. So in my practice, I do follow that. In patients who I've tried anti-mediator therapies, for me, usually they are H1 and H2 blockers, like Sigurd was saying, as well as mast cell stabilizers and leukotriene antagonists. Those are my first sort of, my first set of go-to medications. If I find that symptoms are not well controlled with those, I will go with avapritinib. It's extremely well tolerated. And like you said, Vito, it can be disease modifying, yes, because the tryptase goes down, the variant allele fraction goes down, and the bone marrow mast cell percentage goes down. So you're not just targeting the mediators, you're actually depleting the cells that are really causing the problem.
Thank you. But Sigurd, then how long do I need to treat the patient with avapritinib? I mean, could you tell us about that?
Yeah, that's a tricky question, and that's why you posed it, I guess, Vito, because I think we do not know at this point. We may face young patients with indolent disease, though the symptoms are severe. Are we able then to apply a TKI for many, many years? So this is what we need to find out and make sure that we are helping our patient, make sure that we are also on the long term actually on the right track. But I agree, this is really an interesting and fascinating area of treating patients with mastocytosis. We have new options. I've been working with this for 15 years. We've had mapping patients with severely impaired quality of life, not diagnosed correctly, delayed diagnosis, needs of multidisciplinary approach. Now we are actually able to do targeted treatments, more aggressive treatment, helping our patients in a better way. That's really fascinating.
Great. You touched about the therapy, but Petri, could you tell us how would you follow a patient with an indolent disorder, with or without be treating with a TKI? Would you follow him monthly, yearly? How would you follow? Which kind of tests are you going to ask when you follow your patient?
So, Vito, for ISM, we're really trying to relieve symptoms. As Sigurd said earlier, for the most part, they have a normal life expectancy. Maybe 5 to 10% may progress to aggressive forms. I've actually never seen that happen. So in my practice, I do, again, this is a good forum to emphasize this. I do work with our allergy colleagues, who monitor them actually more frequently than I do, if they are not on a TKI. So if they are not on a TKI, it's just anti-mediator therapy, then I actually take the back seat, and it's the allergist who primarily monitors them, and I see them about once a year. Now, if they are on avapritinib, then it's a lot more frequent, because even though it's extremely well tolerated, it is a TKI, and it is something we are perhaps a bit more used to as oncologists. And I tend to follow them quite a bit more frequently. I'll see them initially in 2 weeks, get labs, and a month. And then, if everything's going well, then we space it out more.
Let's go back to the allergist, because we mentioned anaphylaxis. I mean, which kinds of other measures do you take for preventing anaphylaxis? Can you tell us more about the relationship with Hymenoptera and the treatment that you start, and even if it differs also with the population of Hymenoptera allergic patients that do not have mastocytosis?
Yeah, that's an important point. And of course, not all patients with non-advanced disease do have anaphylactic episodes, but we do find patients with severe anaphylaxis, especially triggered by Hymenoptera venom sting, as you say. And then you need to make sure that some of these patients, the majority of these patients, are eligible for immunotherapy, so they can actually get vaccinated for the allergy and get protected in that way. So that's a major step for many of these patients to protect them for another anaphylactic episode. As I mentioned before, you also need to provide an adrenaline autoinjector on these patients. And one major difference between normal patients with wasp or bee venom anaphylaxis is that to properly protect those patients, we might want to do this lifelong. That's at least the majority of the major opinion on these patients. So stopping that treatment on after 3 or 5 years, like you normally would do, those patients may face re-anaphylaxis later in life. So in our sense, we do it lifelong. That's maybe your point, Vito.
Thank you. Thank you. The last question, Preeti, what about Dexiscan? I mean, you told that it is an important comorbidity. How often, how frequent do you perform the Dexis during the follow-up of your patients?
I get it in all my patients when they first come, of course, but after that, I usually do it every 2 years. If it is normal, if it is osteopenic or osteoporotic, I'm usually getting endocrinology involved. And they'll usually put the patient on a bisphosphonate or at least calcium and vitamin D, and they usually denosumab in certain situations. So they will generally drive it from there. But typically, I do it every 2 years if it's okay.
Thank you. That means that for indolent disorder, we are at the beginning of a really fascinating journey where we start having disease-modifying medication. We are still to finding out the ideal patient that is candidate and how to select those patients. But let's move now to the advanced form. What are the therapeutic options there? Preeti, can you tell us?
Well, for advanced disease, there are a few options. Again, the approved options would be the TKIs, midostaurin and avapritinib. But before the TKI era, a lot of cladribine was used. Cladribine, of course, is a conventional cytotoxic agent. You give it for repeated cycles. Usually it's 5 days per 4 weeks or so. Interferons have been used, but less so. And I believe not much use of those happens any longer. I would say cladribine and the TKIs are really the drugs that we use, but more and more the TKIs. With midostaurin, which was approved in 2017, the problem is that it is a very it's got a broad spectrum of kinase inhibition, so it's not by any means specific for KIT or for mutant KIT. It's got multiple targets and also a fair amount of GI toxicity, so it's a difficult drug to use. I think mostly we would use avapritinib, which is very selective for the mutant KIT, spares other kinases, much narrower spectrum of kinase inhibition, and certainly from the GI standpoint, better tolerated, although avapritinib does have some unique toxicities, such as cognitive adverse events. So the dosing can be a little bit tricky. The approved dose is 200 milligrams once a day. That is the dose you are supposed to start with. But I think in practice, a lot of us will actually go with 100 at times. And we're talking about advanced disease, Vito, as you asked. Because in indolent disease, just to be clear, it is much lower. It's only 25 as the approved dose.
Is there any concern that you have when you use avapritinib relating to blood counts, for example?
Yes, absolutely. So avapritinib does cause myelosuppression. Even though it is supposed to be selective for mutant KIT, it is not entirely so. And so it does inhibit wild-type KIT as well, which leads to myelosuppression. In the early trials, there was some intracranial hemorrhages, almost 13% in the early Explorer trial, the phase 1 trial. But then it was realized that this was almost exclusively happening in people with less than 50 platelets. And once that measure was implemented, for example, in the phase 2 Pathfinder trial, the incidence of intracranial hemorrhage went down to much lower, something like 1%. So certainly very important to pay attention to the counts, particularly the platelets. From a intracranial bleed standpoint, definitely don't use it under 50. And then also there are some concerns with cognitive adverse events, which also need to be watched for.
Thank you. The last point, you mentioned that a patient with an advanced disorder might have an aggressive mastocytosis, but also another hematological component, the AHN. How do you treat them?
Yeah, great question, Vito, and very, very relevant to really our practice, because most advanced SM is SM-AHN. So how do you decide which one to treat, right? So there is the SM component and there is the AHN component. Now, there is some data from the phase 2 Pathfinder study that avapritinib can, in fact, affect both components. And this is because the KIT mutation is present in both the mast cells and the myeloid cells. So you do get some benefit from avapritinib in both components. However, I will absolutely agree that that is usually not enough. So usually, if you feel that you need to treat the AHN, you need to treat the AHN. So really the way we approach it is which one is more urgent. So you look at the blasts, you look at the blood counts, you look at the spleen, you look at the symptoms, and decide which component is more urgent to treat, and treat accordingly. If it's the SM, go with the KIT inhibitor. If it is the AHN, go with the hypomethylating agent, or whatever the case may be for that particular AHN, which is why now the next, the next generation of trials is going to be looking at combinations of KIT inhibitors with hypomethylating agents or other drugs for the AHN.
Thank you very much. Hello, we are at the beginning of a fantastic journey in mastocytosis, and I'm happy to discuss it with my colleagues. I'm Vito Sabato, an immunologist, and I'm joined by Preeti Bose and by Sigrid Busby Olsen. We can target mast cell in mastocytosis by targeting the KIT and the KIT mutation, and we have different medications that have been approved or are under clinical investigation. Avapritinib is the molecule that has been approved, but under clinical investigation we have now bezuclastinib and elenestinib, both in advanced and non-advanced form of mastocytosis, and they differ in terms of selectivity for the mutation and in terms of ability to close the blood-brain barrier. We can also target mast cells to specific receptors, for example, inhibitory receptors, or even we can target those mast cells by targeting their mediators. And let's start with the indolent form. Sigrid, could you tell us about new emerging therapies for the indolent disease?
Yes, thank you very much, Vito. So this is really an interesting era as a mastocytosis doctor, because we do have treatments, we do have like a good understanding of the overall prognosis, we do have a good understanding of how to avoid some of the complications and anaphylaxis, we touched on that earlier, but there is still a percentage of patients with indolent disease with severe symptoms, with impaired quality of life. And we so far, we haven't had the proper tools to try to treat those patients, because you don't really want to apply toxic drugs in a patient with a normal life expectancy. So this is really an interesting and a good period that we're moving into, because the pharmaceutical industry is interested in this, and we are helping each other with new treatments. So that you mentioned 4 different TKIs, and there are also some antibodies on their way. Some of them are already approved for treatment. So the next step will be to understand on how to build, because as we mentioned, each patient has their own, let's say, fingerprint, and we do want to have a tailored approach. Some of those patients with indolent disease do not want, we don't need the TKIs at all. It may be a small percentage of patients that we need those drugs, but overall, I'm really, let's say, positive and optimistic on how to apply these new tools.
Yeah, thank you. PC, let's go to the pathophysiology of the disorder and how can we target this disease. Most of the clinical trial that we have in indolent disorder targets the KIT and the mutated KITs. But do you think that this is the only target that we need to address for the indolent disorder, or do you think that we have to expand the targets on this disorder?
I think you're right. KIT does not have to be the only target. I mean, most of the success right now, of course, has been through targeting KIT and especially mutant KIT. And as you alluded to, there are several drugs. Avapritinib is the only one approved for indolent disease, but then bezuclastinib and elenestinib are both being pursued primarily for indolent disease, although bezuclastinib also, that trial enrolls smoldering disease. And these are, you could consider them sort of variations of avapritinib in the sense that they do not penetrate the blood-brain barrier. So that is an advantage, perhaps, from the standpoint of cognitive side effects, bleeds, etc. Although it's very important to point out that at the dose of avapritinib that is approved for ISM, those are not an issue. The bleeds and the cognitive effects really are an issue at the high doses used in advanced SM. But be that as it may, bezuclastinib and elenestinib, are being studied with very promising results thus far. And also, they may have a more restricted, even more restricted than avapritinib spectrum of kinase inhibition. So they may be even more selective with sparing of off-target kinases. Now, in terms of other targets, BTK is an interesting target. There is a study in progress with a drug called TL895. And then, some of the things like lirentelimab, which, we were just alluding to, that's Siglec-8. And so there are different targets, absolutely, beyond KIT that are being explored for indolent disease.
Well, thank you. That means that we have a nice journey on indolent disorder. But Sigurd, a quick question. Again, which kind of symptoms of clinical manifestation of mastocytosis would you like that have been addressed by the new clinical trial that are ongoing?
Yeah, I mean, some of the patients do have really severe skin lesions. Now, that might be not the only target, because then we are, let's say, moving into a cosmetic treatment. But I don't want to underemphasize that some of those patients are really severely affected by skin lesions, and those they do not disappear on antihistamines, for example. They do not disappear on anti-IgE. So you might help their pruritus and flushing, but the skin lesions are still there. So that's one thing that we have not had any treatments for so far in the non-advanced disease, though we do see an improvement on TKIs, and this is one of the things that avapritinib have actually shown a clear improvement. But this is probably not the only, let's say, indication. You need other severe symptoms to apply a TKI. So GI symptoms, we do see patients with severe GI symptoms. We do have more diffuse symptoms with pain problems, with neurocognitive problems, with more diffuse symptoms. So at least at our center, we do see patients with an unmet need of efficient treatments, though we are able to provide off-label anti-IgE. So that's some of the areas that I think we need new tools, and we are getting new tools for our patients.
Thank you. Let's move now to the advanced disorder. Can you tell more us about new and emerging treatment, PT? What you can tell us?
The main drug we are all watching as a field is bezuclastinib. Considering that avapritinib is already approved, as we have said earlier, avapritinib was approved in 2021, actually at a starting dose of 200 for advanced disease. But what became apparent was that at that dose, you do have a fair amount of cognitive toxicity and some concern for intracranial bleeding, although, as we mentioned earlier, that is greatly mitigated if you don't give it to people with very low platelets, which is clearly a warning and something that should not be done. So even though those concerns have been mitigated, there is interest in developing drugs for advanced SM where they will not cross the blood-brain barrier and therefore not have those problems, and also be more targeted than avapritinib by sparing things like PDGFR. So, bezuclastinib is kind of a product of these efforts to try and find something that is more targeted, less off-target actions, and less penetration of the blood-brain barrier. So this is being studied in a trial called the APEX trial. This is, moving along just like similarly designed to the Explorer study phase 1 of avapritinib. So we've seen some early results from APEX, and it looks promising. Very nice reductions of markers of disease burden like tryptase and KIT-VAF and mast cells in the bone marrow. Now, in terms of overall response rate, it's around 56%. And so a little bit lower if you compare across trials with avapritinib, which was more like 75. But then this is still early. This is an ongoing study. So there's more to come on this. And something I alluded to earlier, I'll say again, which is that in the spirit of treating both the AHN and the SM component for patients who have SM-AHN, the APEX trial has been amended to now allow the addition of hypomethylating agents.
Well, you opened the question. So actually trying to imagine and to decide in the future, what do you think about combining the holds? Because you mentioned cladribine or other kind of CYP reduction with TKI. Do you think it would be an advantage that would be placed for these kind of trials or not?
So my thought is that TKIs actually are very good in and of themselves for the SM part per se. So I don't think that the SM component necessarily will need TKI plus cladribine, but I think the SM-AHN is really the bigger issue because you cannot really just treat one and ignore the other, right? So I think adding drugs that target the AHN to the KIT inhibitor are probably the way forward, and it's nice to see that this is happening not just with bezuclastinib, as I mentioned, but also with elenestinib. Elenestinib is again similar KIT D816V TKI with reduced brain penetration, and that's being studied in a trial called Azure in the advanced setting. Azure, which also allows specifically studies the addition of hypomethylating agents to the elenestinib.
Hello, I'm Vito Sabato. I'm an immunologist, and I'm happy to be joined in this panel by Prithvi Bose, who is an hematologist, and Sigurd Bøsby Olsen, who is a dermatologist. Is a disease with a heterogeneous presentation that goes from symptoms caused by uncontrolled mediator release and goes from anaphylaxis, from gastrointestinal symptoms, neurological symptoms. We have skin manifestation in forms of symptoms and in forms also of lesions, and we have also in advanced form organopathy. That means that because we have this presentation, we need a multidisciplinary approach. And I'm happy to ask the first question to Sigurd. Actually, Sigurd, which kind of specialists are important in the management of the mastocytosis?
I think the main message is that treating mastocytosis is a team sport. You can't do it on your own as a dermatologist, and you can't do it on your own as an allergist or hematologist. You need to work as a team. This is also really like what our patients expect from us. They don't want to go from doctor to doctor getting a new, let's say, idea of what is important. So I think we really, in order to help our patients, we need to collaborate. And at our center, we have one entrance, and we sit together, hematologists and myself as a dermatologist, allergist, we sit together, we see the patients together. That may not be possible everywhere, but at least, let's say, working together, having the same understanding, working together with the specialists in osteoporosis, with gastroenterologists, with pathologists diagnosing properly, with even the emergency ward not overlooking those patients, with the GP and healthcare professionals also binding everything together. So to me, it's really important in order to help our patients.
Yeah, Viti, you mentioned the pathologists. How important is the pathologist for the in this multidisciplinary team?
I think extremely important. I was, as Sigurd was speaking, I was thinking of the different clinical disciplines as well, like he was saying. But absolutely, we cannot ignore the role of the pathologist, because simply finding the SM starts with them, right? I mean, in the cases of SM-AHN, it's very easy, I think, sometimes to overlook the SM and not even realize that it's there, and so awareness of the pathologists, doing their trip test stains or looking for the KIT D816V and correlating with that. I mean, I think it's really important to find the SM cases that may be in association with an AHN, because I feel that we still underdiagnose some of that. And also in cases of non-advanced SM, again, Sigurd was saying this earlier, that it is not trivial, their role, because it's a combination of morphology and flow cytometry, mutational studies, tryptase. I mean, there's so many different things, but I think the pathologist's role is absolutely critical. And beyond that, sort of jumping back into the clinical arena, this is a disease that has so many varied manifestations. So you need endocrinology for the bone health. You need allergists, of course. That's key. You need dermatology. Obviously hematology as well. Sometimes neurology, GI. All these do need to be involved, and really that is what, as Sigurd was alluding to, you ideally want to see at a center of excellence, where people really get together and review those cases. But one other thing I'll quickly add is that, I actually find that since many of these patients who may see somebody with expertise in SM may actually not have SM, and they may have MCAS or some other mast cell disorder. And that is where we hematologists usually are lacking in our exposure to those things, or even frankly, our training in those areas. And we are looking to our allergy colleagues, So I think some of those non-SM mast cell disorders also deserve some recognition in that big picture of this multidisciplinary collaboration.
Well, thank you. You touched allergies, and I know I'm an allergist. So when you have a disorder, of course, you would not like to underdiagnose, but also it's extremely important also to avoid the overdiagnosis. And you touched about those mast cell activation. Sigurd, can you tell more about us and how important also is the not overdiagnosing of these disorders?
Yeah, that's an important point, and also nice to address that, because many of the symptoms that are described in systemic mastocytosis are not are subtle or non-specific. We mentioned, for example, the neurocognitive symptoms: lack of concentration, depression, pain in the bone, different, let's say, varying GI symptoms. So many of those symptoms are not specific, and even the tryptase measurement is not specific for mastocytosis. So we do face patients that are not really, let's say, ill in the systemic mastocytosis area, and maybe not even on their mast cells. So we do need to figure out not to overdiagnose mastocytosis and mast cell disorders. And this is where we need, let's say, a good balanced discussion, because many of those patients actually should have another diagnosis, or should, let's say, have another specialist treatment. So we also need to rule out sometimes mastocytosis. I do want to mention again the KIT D816V mutation in peripheral blood as a tool in, let's say, an unspecific symptomatology, where you actually could, let's say, decide on this patient does not need a bone marrow because the symptoms are so unspecific. Maybe that's what you are talking about, Vito, because we need sometimes to balance the diagnostics.
Yeah, well, let's touch another point about the multidisciplinary approach we haven't touched. What about the role of psychologists in the multidisciplinary team in patients with mastocytosis, also taking into account for the indolent disorder that is a chronic disease?
Yeah, I can start because I mean, the systemic mastocytosis is a chronic disease, so just having a diagnosis may actually, let's say, have an impact on the daily life. And then again, also the mast cells probably produce mediators that affect our, let's say, brain, and there are different, let's say, aspects on that, also difficult areas, and our countries may vary on what options you have here. Some may just need like, let's say, good counseling on the expert side on our MDT centers or reference centers with support from families. Other may do need psychologists or even psychiatrists. So that's a difficult area, and I don't have one true answer for that, but you don't want to, let's say, you shouldn't underestimate that part of the disease, because that's an important complication of systemic mastocytosis to my experience.
Absolutely. So things like brain fog, and depression, these are so common. And I think the role of the psychologist, as you noted, or psychiatrist, can be very vital. And you guys know this better than I do, I'm sure. But things again, I'll go back to what I said about MCAS and HAT. These entities, I believe, can also have some of these types of symptoms, and so I think mast cell disorders as a whole likely need the expertise of psychologists, neurologists, etc.
Well, thank you very much. I think we are convinced that a multidisciplinary team is extremely important. And if we can close with a motto, we can say that together we are stronger. Thank you.